great.
Is my audio also good, or
what's that?
Is my sound good enough?
It is. I think
Yes.
it's good. Yeah,
Okay.
I think it's really good. Yeah, we're just now getting a lot of people in here. I think what I'll do is start with the with little few introductory slides, and then I'll turn it over to you. And you know, and hopefully by then we'll have a lot more people to join. So thank you so much to everyone for joining today. You know, these are just the standard slides typically show mostly, but you know, thanks to everyone. If you have any ideas, you know, please let me know for speakers. And you know, as you know, we are less than a year to the next Banff meeting, exactly almost. So you know, we're going to try to start in full force, kind of coming up with something to do from this group, a work product. I think it would be really good. I wanted to note that Kidney Week is in a month. So that, and, you know, our aims are here. So obviously we want to, you know, continue thinking about image banks and algorithms. This trial that Dominique has that she's going to talk about today is amazing. And, you know, I'm glad that we've been able to help her with that, at least think through some of the ideas and also publicize it some. And then the last, you know, goal is for us to rethink the innovation timeline. So in 2 weeks, Majid from the University of Alberta will speak. That'll be really great. You know, he's done a lot of great molecular work with Phil Halloran, and he's also worked with Kim Sola as a great bit. And then and we won't meet during the week of Kidney Week. But around November the 23rd, we will have a planning session. We're going to try to plan the next year and who can speak. So, you know, give that some thought. And then on early December, Drew Williamson, who's a really great, you know, researcher here with AI. He's part of Faisal Mahmood's group. He was before he came here. To Emory, and he the same group that Sharifa Sahai, who used to join a lot, you know, is part of. And then we'll during the holidays we won't meet. So the first meeting we'll have in the new year 2026 will be around January 15th or so. And so you know, we look forward to that. And again, please let me know if you have any ideas. But I think in the interest of time, I don't want to take too much of Dominique's time. I'm going to go ahead and turn it over to her and thank her so much for speaking today.
Yes, hi everyone. Thank you for the introduction, Brad, and also, yeah, it's a great pleasure to be able to present again. I will try to share my screen first. Yes, I think it should be visible for everyone.
Yep, that looks good. Thank you.
Okay, great. Yes, I asked ChatGPT to make an illustration of the content of this presentation, and this is what came out. As many of you know, also thanks to Brett, we recently started with the final phase of the Diagraft project, which is the reader study. So my idea for today's talk is to outline the preceding steps a little bit, what has led up to this point, also to maybe give some background on the models for the people who are joining the reader study to know what they are looking at. And I will also present a little bit on the setup of the reader study. Of course, I can't reveal too much because the people who are participating, I don't want them to be too much biased by what we know. But I can at least present the setup. Yes, our research group has been working on AI for kidney transplant pathology for quite some time now. The first model that was published was already in 2019, the multi-class structure segmentation model. And this was also the starting point of the Diagraft project, as we applied for a Success Accelerator grant from the Dutch Kidney Foundation, with the idea to use this segmentation model as a foundation and further enhance and extend it towards automated bench scoring. So in the meantime, we developed the PTC segmentation model. I already presented a bit on that work in another Banff digital pathology working group session. And we had the monkey challenge for the detection of inflammatory cells. So I want to start with a quick recap of the monkey challenge, which is an acronym for machine learning for optimal detection of inflammatory cells in kidney transplant biopsies. And this was a multi-center cohort of PES stained biopsies, which was collected, and the slides were annotated for lymphocytes and monocytes based on a immunohistochemical restaining. So we had the slides scanned first, the PES slides, then restain them with immunohistochemistry for lymphocytes and monocytes to be able to make the annotations, so have a strict ground truth. And this data, so all the images, also the annotations, were shared on the Grand Challenge platform, which is an online platform where people can participate to the challenge, compete with each other, trying to develop the best performing model. And for this challenge, it was the task to detect inflammatory cells. We had quite some requests from all over the world. In the end, 135 submissions were there for the live leaderboard phase, which is more the initial development part. And in the end, 7 teams went on to compete in the final test phase. I have the results from the top 3 performing teams, where the Diagraft team from the Tissue Image Analytics Center from the University of Warwick, UK, has won. That was the first ranking team. InstaSec, which is a team from the University of Edinburgh, was second, and Error Matrix was third place. We did use the FRC metric for ranking the teams, but we were also interested in having a little bit more insight in precision recall metrics. So we tried to identify the optimal trade-off between precision and recall by adjusting the probability threshold, so you can make this precision recall curves and see where the models for each team was most optimized. And we chose to try to at least reach a precision of 0.7, or at least that was that seemed to be the most optimal point for most of the models. 0.7 recall precision, it seems fair to moderate. I don't know if it's good or excellent. It isn't perfect, of course, but it's a fair to moderate performance score. We also had we tried to challenge the participants a little bit more and see if they can, if their model would be able to differentiate between lymphocytes and monocytes. But this turned out to be a quite difficult task, where the performance scores are suboptimal, at least in our opinion, insufficient to really use. I don't blame the models for having difficulties with this task, because differentiating monocytes and lymphocytes is quite hard based on PES only. We had, of course, the immunohistochemistry, but the models were trained on the PES. And here I have an example where you see 2 cells on the left, which where there are some box around them. To me, I would have set on the PES like probably these are 2 lymphocytes, but you see in the restaining that one of them is monocyte and one of them is a lymphocyte. And another example is on the upper right, where you also see 2 cells. I would have preferred, or I would call them histiocyte of monocytes if I had to choose something on PES based morphology. But the immunohistochemistry shows otherwise. So I think, it's just a quite hard task for AI to be able to differentiate on PES. I can at least show what the output of the model looks like at the moment. So this is a case with quite some inflammation, also tubulitis. And the model now has this output where I think you can nicely see the pattern of inflammation, and also it highlights the tubulitis. So I think that this was a nice visual outcome. So a recap of the findings. We are quite satisfied with the performance for overall inflammation detection. So it's suboptimal for the differentiation between lymphocytes and monocytes. Also, we saw that it was suboptimal performing for biopsies with little inflammation, and that probably has to do with the underrepresentation in the training data. So we selected, or we included cases based on the morphology, and we tried to put in everything that you can see in routine diagnostics, especially focusing also in inflammation and scarring, because we think it at least should be trained on those samples also. But that resulted in a little bit less of the cohort having normal biopsies. Yeah, we had a quite strict ground truth with the immunohistochemistry restaining. And I tried to evaluate the false positive detections, because we have the precision recall of 0.7. So what are then the false positive detections? Partly some annotation mistakes. I think we always keep them if you work with annotated data sets. Even with the immunohistochemistry that we used as ground truth, but then sometimes you have some weak staining, which made it more harder. But these are not a lot of numbers of annotation mistakes. And we also see that some other types of inflammatory cells, endothelial cells and smooth muscle cells, sometimes get picked up by the model. So that's a little bit of the pattern that we see at the moment. Yeah, the monkey challenge was a key component of the Diagraft project. But now, before we can move on with the actual Banff scoring, we wanted to review the previously developed models. Like I said, we had the multi-class segmentation model and the PTC segmentation model. We had to see if they were still executable, because the multi-class is already from 2019. And we also wanted to see if there was room for improvement. For the PTC model, we originally designed a UNet model with a ResNet 50 backbone. Also on a set with biopsies, including challenging morphologies like severe inflamed biopsies, but also severely scarred biopsies, which was, I think, not done in the recent publications. There were some publications already on PTC segmentation, but most of them had minimal change biopsies. There are also publications with transplant biopsies, but I think that's a strong point for our data set, that we included challenging morphologies. The model shows potential with the dice of 70%, but there might be room for improvement. And one of the reviewers of the paper rightly noted that with this performance, you have 30% of PTCs that are being missed. You can say that is bad performance. On the other hand, it's also quite challenging to define the target score that we should strive for. For example, we don't know how pathologists perform on this task. I get the question a lot of times when I present a little bit on the PTC work, like how well do pathologists detect individual peritubular capillaries? Well, we don't know. It's also a quite hard task to point out each individual PTC in a PS staining, especially in inflamed areas and scarred areas. I did try to compare it a little bit with the ground truth of the data set that we had for this PTC model. And we saw that the more severely inflamed PTCs, like PTC2 and PTC3, they were generally correctly being detected by the model. So the majority of the false positives or false negative detections are the non-inflamed small PTCs. We also saw that the false negative PTC detections in the biopsies with PTC1 would not affect the whole slide score of the model, because you need more than 10% of PTCs to be involved to call it PTC1. So in general, it didn't change the PTC scoring. It did change for the original pathology report, because we saw that the PTC score was different for 9 cases. And from these 9 cases, it changed from no to mild peritubular capillaritis to moderate severe peritubular capillaritis, where the model was right. If you look back at the ground truth annotations included this PTC2, PTC3 cases, but it was not in the original pathology report. So I think this demonstrates the potential of AI to help pathologists in routine scoring. Well, coming back on the room for improvement, we were wondering if the NNUNet, which has been developed in 2018, might show improvement of the baseline model that we have now, because the NNUNet, unlike most other models, does not require extensive manual tuning of hyperparameters. So it automatically adapts its architecture and training schedule, pre-processing, post-processing steps based on the characteristics of the given data set. So that might be quite simple to implement improvement for this PTC model that we had before. And here you can at least see on the right is the previously published UNet. So this is an output with the UNet like in the how it was published in the paper. And now on the left we see the NNUNet output, where you see some additional correctly detected peritubular capillaries, and the false positives in the UNet are not in this NNUNet anymore, which were, I think here you have some kind of, how do you say, the vasa recta where you're looking at. So these are larger vessels which shouldn't have been picked up as PTCs. So with the NNUNet, we saw an increase in performance, mainly the precision increased, which you can also, of course, then nicely see with the decrease of false positives. And there was also a mild increase in recall, so less false negatives. Yeah, we did this. We tried the NNUNet approach also for the multi-class segmentation, but there you see only minor improvement. It already was a quite well-performing model. I think especially the atrophic tubules, which were already a challenging structure, it improved a little bit, but I think this is the structure that the model struggles with the most and still struggles with. And we see here that in the that the atrophic tubules are being misclassified as normal tubules. So that's the most mimicker for the atrophic tubules. Here the PTCs weren't included. So if you look at the slides visually, you also see that some of the atrophic tubules are PTCs, but these weren't in this data set included. Yeah, maybe it's good to know that both models now are published on Grand Challenge, so you can request access and try out the algorithm by loading images. So that's nice for people who want to try it out. And yeah, for the Diagraft project, the next step was to integrate the 2 segmentation models into one final segmentation model. And both models seem to perform well and probably can complement each other. We had 3 options to do this. One idea was to just put all PTCs on top of the interstitial class of the multi-class segmentation model. So then you would only see the PTCs that are in the black area in this image. Another idea is to use PTC as ground truth. So just everything that the PTC model picks up, just put it on top of the multi-class segmentation. And then a third option is an uncertainty-based segmentation. Just see, especially for the tubules in the multi-class segmentation, if it's more uncertain, then it should score it as a PTC. So just looking at both of the uncertainty masks. And here I can show a little bit how it looks like. So on the left option, you see the PTCs just on top of the interstitium, so not looking at uncertainty uncertainty scores. Let me see if I can show it. Yeah, you have here some structures. The segmentation model seems to struggle with these structures. It now looks like they are atrophic tubules. In real, they are PTCs. And then when you look at the option 3, so uncertainty-based segmentation, it correctly now picks it up as PTC. So this would be the preferable option of these two options. And looking at the PTC as ground truth, then it maybe gets a little bit harsh, because for this case, it looks like the PTC as ground truth is the best option, because these are indeed PTCs. And in the right image, you see that it might segment it as atrophic tubules. But I was questioning a little bit if we will go for this PTC as ground truth option, if you then have cases where you will miss atrophic tubules. And that seems to be the case. So this is another biopsy where if you use the PTC as ground truth, then some tubules are being detected as PTCs. So we eventually decided that the task 3, so based on the uncertainty-based calculations, it is the best performing model, or the best way to combine the two segmentation models. So what does the final segmentation model now looks like? Here I have a case where you see both of them on their own, so the multi-class segmentation and the PTC segmentation. And when you combine them, you get this integrated segmentation output, which I think is a nice result of combining both models, where you can, nicely also see the PTCs. So now we have the combined model, and that was a little bit like the first moment of truth. So now we worked for some years on developing AI for structure segmentation and cell detection, and now we have to see what happens when we run both models on a single whole slide image. Does the results still make sense? Will it work? And on one hand, I was quite impressed together with my colleagues, because it nicely seems to capture all structures, and also the pattern of inflammation, where you see the different densities also. And I think also the IFTA on low magnification, you immediately have some kind of idea on the chronic damage, and the inflammatory cells are easy to see on low magnification. Another question I often struggle with is, how do we balance algorithm precision versus practical usefulness? I think AI models are being strictly evaluated, which is also good. But I think often this leads researchers trying to perfect the models endlessly. I think we also we have been working on the models for quite some time now. When is it good enough? And sometimes I'm a little bit torn between what can we accept, what performance should we aim for? Is it important for the diagnosis to have a precision of 0.9, for example, for PTC segmentation? Or is the current model already of added value as a supportive tool? And especially at this stage, we see it more as a supportive AI tool rather than decisive tool. Of course, in research setting, you can argue this, as it would be a very helpful tool if AI can review thousands of biopsies that you included in a cohort, for example, and give an automated bench scoring. But then it has to be very precise, of course. So that's a little bit like the trade-off, clinical implementation or a supportive tool rather than decisive tool. Yeah, what is now next? The Diagraft reader study, where we aim to evaluate the impact of the use of deep learning on pathologist performance in Banff scoring. And there we will focus on the effect on inter-observer variation. So what will happen for the individual Banff lesions and also for the final diagnosis. We are curious to see if a group of pathologists score the same biopsies, what will happen with the inter-observer variation. And also, this allows us to get a little bit insight in the preferences. So how do we want to work with the AI as renal pathologists? And as it is a quite time-consuming task, we thought we can't ask for more than 30 biopsies to be reviewed by each pathologist. And Banff scoring is quite time-consuming, and it also has to be done twice. So the task we ask for is that pathologists read 30 cases without and with AI assistance in 2 rounds. They have to assign the individual Banff scores and also assign the diagnosis. And the workflow that we came up with is that pathologists will be assigned to one of the subgroups. Images in both sessions are the same and will be displayed in the same sequence, but the way that they get reviewed, either with or without AI assistance, is different. So here you see that each square represents a set of images, so 6 images, with the color indicating whether the modality was unassisted or AI assisted. So in this first group, order 1 will start with 6 cases unassisted and then switch to 6 cases with AI assistance. And this is with the idea that we can correct for confounding due to short-term learning adaptation, because we think that the readers also improve during the reader study as they will get used to the platform and also the AI. So by alternating, we think we can keep it fair. We currently, I thought I should already be happy if I have like 10 or 20 pathologists that wanted to participate, but at the moment I have 80 people who want to participate, which is nice because then we can have multiple groups of 30 cases that we can, that the pathologists can assess with enough pathologists per subgroup to assess the 30 biopsies. And like I mentioned, we do it twice because in one, you have the same cases in another reading modality, and in between there will be a at least 3-week washout period. Because you might think we have collected cases from different centers, the models are ready to go. It should be quite easy to set up. Just start with the Diagraft reader study. We had to pre-process some slides, and then we also discovered some inconsistencies. For example, some of the slides had some pen marks because we received the whole slide images, so not physical slides. We can't remove the pen marks ourselves, but we had to come up with a solution to do this also with AI. And there was one of the centers that had this red background, which might not be an issue. I think we can ignore it as pathologists, but it looks maybe a little bit ugly. So in my team, someone helped me out with removing the pen marks and removing the red backgrounds. And we also see some staining variation, which of course is normal because that's what we wanted. We wanted to have PES stainings from multiple centers. But we do know, especially for the segmentation models, that you see suboptimal performance, especially in the weakly stained PES staining. So here you have a biopsy where you already easily see the PTCs and they are missed by the model. So we tried cycle-GAN staining normalization, thanks to Linda Studer, who helped me out with that, which makes it more resembling to the training data. And then you see a better performance of the model. So then the PTCs are being correctly picked up again. I think it's something that we have to work on in future, because we want the model to be to work on all kinds of PAS stainings, of course. But for now, we chose to do the staining normalization. So here you see the centers stainings on the upper row, and after restaining, they look a little bit more like the staining that the segmentation models were developed on. Yeah, we also had to figure out how to work with the Grand Challenge website. So that's the place where the reader study will be hosted, so where the pathologists can log in and assess all the cases. Yeah, we had to upload the images, of course, and create a questionnaire and instruction video, which is quite straightforward, of course. But we also had to do some bug fixing, because we now had our images and AI outputs. But in comparison with the monkey challenge, where we only had these tiny regions of interest with inflammatory cells, we now had it on whole slide. So the whole slide, this is an example with a lot of inflammation, so it turns blue due to all the dots. In this case, there were more than 300,000 dot annotations. And yeah, this was a large file which caused the Grand Challenge platform to crash. So we had to fix this to see if we can work with this annotation data, but have a more smaller file, so that the Grand Challenge website can work with these annotations, because it's, for some case, a lot of annotations that need to be loaded. And that's something that the Grand Challenge support team had to work on. So they helped us out trying to find a solution. And now it is working. So that's something that was solved next to some other bug fixing things, but I won't go too much into detail now. Yeah, we invited pathologists, needed to create different subsets, and now it is ready to go. So we have the reader study online, and this is how the viewer looks. So you have the original PAS on the left, AI output on the right, and the images are linked. So if you scroll through the slides, they remain aligned, and you can toggle on and off both the structures, but also the inflammatory cells. So you can see how you want to use it, because I can imagine that there are a lot of colors, there are a lot of structures, so maybe it's a little bit overwhelming, and also something that we are curious to learn from the pathologists, what their idea would be, how they want to use these kinds of models. Yeah, I also I already forwarded the instructions to pathologists who have indicated that they're interested in participating, but there's still room to join. So feel free to contact me. And for example, the deadline for the first session is by the end of October. So still a couple of weeks to go for the 30 cases to be assessed. And yeah, with this data set of 180 biopsies in total, so there will be 180 biopsies in the reader study, we can do different kinds of evaluations. So yeah, the reader study hopefully provides us with insight on inter-observer variation and also user experience. On the other hand, we can evaluate the AI on its own by converting the AI masks to Banff scores directly and see how how it will score Banff items and what kind of final diagnosis will come out of it if you just look at the mask on itself. So that's something that we will do in the meantime when the reader study is going on. Yeah, for me, the reader study is a second moment of truth and a quite scary one, as we now put our model out in the open. And well, 70, 80 renal pathologists have responded to be interested to participate. So I do feel quite a bit of pressure because there are certain expectations. I do think it's good to keep in mind that this is a first prototype model, somewhat a pilot study. I think it's a realistic output that the model shows, but it's not perfect. And that's also, I think, what makes this reader study valuable, to see what we need to focus on next to further develop AI for kidney transplant pathology. So I'm very curious how it will be received. I already mentioned I cannot reveal too much on the output of the reader study slides, but I think it's also a good moment to discuss what people might expect from AI models and to see, how are we going to use it? Are people wanting to use it as it is now? And because here we have an example at some higher magnification with quite some interstitial fibrosis. And I think overall, at the first glance, it looks good. But once you look in more detail, you can spot some errors, that some PTCs are not being fully segmented. Maybe even some atrophic tubules are hard to, here's an example, here's not being detected. So it's detected as interstitium. So yeah, that kind of errors that you will see in the output, and I think it's not completely to blame for the AI, because it can be quite hard. Another thing to keep in mind is that the inflammatory model from the monkey challenge was trained for lymphocytes and monocytes. So neutrophils are not included and therefore not detected at the moment. But of course, they should be included for Banff scoring. So that's something that we need to keep in mind when using models. And this is a similar example where you see here also quite some glomerulitis, but also with neutrophil, and it's not being picked up by the model at the moment. Same goes for plasma cells. So here you see that it's not picking up plasma cells. On one hand, it's I think a good sign that it's able to differentiate between neutrophils, plasma cells, lymphocytes, and monocytes. Yeah, so to wrap up, we have developed AI models that can mimic Banff classification. The models have been trained on PES biopsies from different centers with the spectrum of morphologies that you can encounter in routine practice. We made use of immunohistochemistry to create ground truth annotations. We see some satisfactory performance scores, and visual output also looks nice, but it's not perfect. The reader study has started, so our team is eagerly awaiting the results, and we are very curious to see how it will be received. I think at this moment, the feedback from pathologists is crucial to be able to continue optimizing everything. And maybe it's not all about performance scores, but about how AI helps pathologists and patients, of course. So with this, I want to thank everyone for the attention. This work wouldn't have been possible without the help of all the participating centers that provided us with data to train the models, and also now for the reader study, and especially also the input and efforts from the monkey teams from the monkey challenge, which resulted in the inflammatory cell detection model. So I'm happy to answer questions, give room for discussion. I think there are enough things to discuss about, maybe.
Wow, that was really amazing. Your figures are really cute, and so you did all those with ChatGPT?
Yeah.
Oh wow, that's amazing. Yeah, I like the look of them. Well, I have a lot of questions, but I want to let everyone else go first. So yeah, I think but thank you for that. It's awesome. Anybody have any questions or comments? Well, I could start off. So the algorithms that are already ready to use, and you showed that kind of looks like the ones that are on, like we have Sectra here at our hospital, and it kind of looks like ones you could plug into Sectra. Is that true, or do you know?
It's a good question. I know from our hospital we are not able to yet incorporate them in sector, but I do think that that's something they built in. So some, how do you say it? Some centers are able to use or to plug in, indeed, like you mentioned. But we don't have experience at the moment. We are still working on it. Actually, we have everything still in research setting, which is a little bit disappointing, maybe. But I know a team is working hard to keep to try to, um, yeah, have the next step towards diagnostic implementation, especially for some other models like methodic counting, etc. Sentinel node, metastasis, that kind of models.
Yeah, we have a few things on Sectra, but unfortunately, like yeah, it's very hard to add the algorithms
Yeah.
during our experience. Uh, Richard, do you have a question or comment? Saw him come.
I have one question.
Yeah, sure. Yeah, Saki.
So, hey Dominique, great talk. A question is about that maybe halfway through your talk, it's like when you found out that on PAS you cannot really distinguish two different types of cells, right? Only
Mm-hmm.
by special staining. So, uh, yeah, we understand this now, but how can this be resolved? I mean, how can you train the
Yeah.
model to on PAS, for example? In my case, I don't have access to the special stain. It would raise the cost and everything. But for example, how can you really train the model just on a PAS to distinguish two cells that look identical, but they are indeed different?
Yeah, I think it's an important problem. I think we thought upfront a little bit too easy about it. Like, oh, it's easy to hey, you have morphological characteristics of cells to be able to differentiate them. But now, yeah,
Yeah,
we see
this.
that
Yeah,
it's not this easy. And or at least it became more clear when you look at the immunohistochemistry and really have to annotate each individual cell, then it becomes clear like it's not that easy as we thought in the beginning. Um, I know there are. I was curious. There have been studies with more multiplex immunohistochemistry because this is really limited to two cell types. Maybe you need more data. Maybe, yeah, it would be maybe other types of models or architectures. I'm not sure if there are more fancy deep learning approaches because we didn't yet try too much on this data for this task and just focus on inflammatory cell overall for now. But it would be something to see if, yeah, you can do more with this data because we have quite some slides, we have quite nice immunohistochemistry. So yeah.
yeah. And maybe a question for pathologists now. Like in everyday practice, is it important for you to distinguish these types of cells, like on a regular caseload, or if you just score inflammation? In which instances is important to say, okay, there is 3% of this, or 0.5% of these cells?
Yeah, that's a good question. I mean, like, yeah, we don't routinely, like, for example, kidney transplant biopsies, Banff is written for just standard, H&E or in a PAS and maybe a Jones and a trichrome, the seven, sort of like 7 slides,
Yeah.
like 3 H&Es and, like 2 PASs and Jones and trichrome. I do sometimes stain for CD3 and even sometimes like with CD68 from macrophages because there have been some macrophage rich rejections described like by Alan Kirk, for example. I think Bonusis there's a paper with probably with Kim on that paper, and it was with certain immunosuppressions, you do get rejections that are macrophage rich, but for the most part, we don't actually distinguish
Yeah.
those. It's in Banff, it's just and actually, it's usually called, that's actually why I prefer the term acute cellular rejection rather than Banff says T cell mediated rejection, even though there are some cases that'll kind of look similar, but Kim should probably be talking because he knows way more about this than I do, or Lynn actually even. But would you like to say something, Kim? Guess, or Lynn?
Maybe I can jump in and
I
ask.
can say something.
Whoop,
Oh, I can
sorry.
comment on that. Um, I, I, just in your, routine practice, no, I don't distinguish that. I just call them mononuclear cells
Yeah.
because, and just to correct Sasha, they do not look identical, but, depending on your section, you may or may not be able to tell a difference, but it doesn't really matter. And then in terms of capillaritis, if you do CD68 stains and CD3 stains, the capillaritis is a mixture of these cells. But I was surprised. So I don't think practically it really makes a difference. And especially in terms of Banff scoring, doesn't make a difference. But what might make a difference is the ability to recognize neutrophils. And I think that's really important to look at in the future because neutrophils, of course, you see with endothelial injury and acute antibody-mediated rejection. So I would think that recognition of neutrophils may be more important. And I have a question for Dominique. What would neutrophils be assigned? I mean, what category would they be assigned in? Because that's part of our capillaritis scoring. We don't just score the mononuclear cells, we also count neutrophils, and often we have a few neutrophils mixed in there.
Yeah, it's true. Yeah, for different Banff lesion scores, they are included for Banff scoring, of course. So it was not something that we excluded for this study because we didn't think they were important, but just to keep the restaining protocol a little bit easy to go. Try to focus on the two most important cells, and that's why we came up with lymphocytes and monocytes. But plasma cells and neutrophils should be definitely in there. Also for glomerulitis and PTC, indeed, you need to include them.
So I have a question. It's this is Richard Levinson, and it has to do with the fact that I'm not a renal pathologist, and I am an aficionado of H&E. And I'm wondering, now that we have these amazing modal conversion powers in AI, where you can take an H&E and turn it into immunostains or PAS or something else, whether it might not be possible to switch the basic image to H&E, derive the PAS information, but also, I think, get better detail on the inflammatory cells and other details in the system.
Yeah, I think that's a very good suggestion, actually. Yeah. Also for the cell morphology, it's more easy to appreciate in routine H&E stainings for some types of inflammatory cells. So that would be maybe a smart solution to look into.
Good luck. Start over from scratch, right?
Yeah.
All
Well,
right.
we can just transform them, right? So
there you go.
it still work.
Are you able to get any estimate of how long? 'Cause I know I'm trying to figure out how to budget this time because I really want to help, and unfortunately it's a busy month for me, but also it might be interesting to know the time. I know it's because people can log on and then they go do something else, so it's you can't get a good estimate of the time. But it would be interesting to know because people ask me, how long does it take you to Banff score case?
Yeah.
And it's always like, it's always, it's hard for me to give an answer sometimes.
Yeah. It's something that we thought of to have some kind of time measurement in the reader study, but because you now also have the AI visual assessment, I think it will not be a fair representation of routine scoring of Banff, where you now only have to you only have a PAS and now also have AI that you are new to and maybe curious to see what it does and where the mistakes are, etc. So we thought it will not give much information. There will be a lot of variation, we believe. So we didn't include it. And I think Grand Challenge also doesn't allow for it at the moment. So that's unfortunate also.
For time, I have some ancient history on that. When Banff began at the first Banff meeting, we had the data that there had been a study in Reykjavik, Iceland, showing that the average complex surgical path case takes 29 minutes to diagnose. And we vowed that whatever we did, that we try to keep within that same metric of the 29 minutes. So anyway, that was a long time ago, but that was data from 1990 or 1991, I think.
Well, I'm really amazed at this, all you've done, and I appreciate your presenting it again, and I think it helps us think about it's helped us think about the ones who want to participate, what you actually need and everything.
Yeah.
Yeah. Any other questions or comments? Well, I guess we'll plan to meet in 2 weeks, and I look forward to that presentation also. But this has been awesome, and love the way you illustrated it. It was beautiful.
Thank you for giving me the opportunity to present it.
Great. Well, thank you all so much, and see you later. Yeah, thanks a lot.
All
Take
right.
care.
Bye.
Bye-bye.